Welcome to Cortex Conversations. In our deep dives, we take your shared sources and extract the knowledge and insights that really matter.
And today, we're diving deep into autoimmune encephalitis, AE for short. Specifically, we're focusing on MRI and the really crucial role it plays in understanding these conditions.
Right. The sources you shared give us a pretty detailed look at MRI findings across, well, quite a few types of AE.
Exactly.
Now, I know encephalitis, brain inflammation, basically, and MRI findings might sound a bit heavy, maybe technical, but trust us, we're going to unpack this, make it clear, engaging, and really give you the key info you need without getting, bogged down.
That's the plan.
Our mission today is really to get a handle on how MRI helps identify and characterize these different autoimmune attacks on the brain.
Yeah, what are we actually seeing on those scans?
Exactly. Are there specific clues for specific types of AE? And can MRI tell us anything about prognosis, how things might progress? We know you want to get up to speed quickly but thoroughly, and that's what we're aiming for.
Definitely. And we'll cover a whole range from the, let's say, more widely known NMDA receptor encephalitis all the way to things like GFE astrocytopathy.
Wow, okay.
It highlights just how diverse these conditions are, both clinically, how they show up in patients, and crucially for us today, what we see on the MRI.
Right, and maybe we should keep in mind the challenges clinicians face trying to tell these apart.
Absolutely. MRI isn't perfect. It has limitations, but it can offer really valuable clues.
Okay, let's start with NMDA receptor encephalitis then. This is probably one people might have heard of. Clinically, what are we looking for?
So often it starts with what we call a prodromal phase. Think headache, maybe a fever, sort of flu-like sometimes.
Okay.
But then it progresses. You start seeing significant behavioral changes, psychosis, sometimes losing touch with reality,
Right.
affective symptoms, so mood changes, memory problems. Seizures are common too.
Seizures, okay.
And sometimes these distinct movement disorders like orofacial dyskinesia.
And just to clarify, orofacial dyskinesia, that's like involuntary movements of the face, the mouth area.
Exactly. Chewing motions, lip smacking, things like that. You can also get autonomic instability problems with heart rate, blood pressure, body temperature control, and altered consciousness.
That sounds like a lot. What about long term?
Yeah, long-term, people can be left with cognitive deficits. Memory is a big one. Also, executive functions planning, organizing thoughts.
Right, the higher level stuff.
And fatigue, depression, anxiety, sleep disorders. Those can persist too. It's a wide spectrum.
Definitely. So with all that going on clinically, what does the MRI typically show in the, the acute phase?
Well, this is where it gets interesting and maybe a bit counterintuitive. In the acute stage of NMDA receptor encephalitis, the MRI is often normal.
Really, even with psychosis or seizures?
Yeah, in more than half of patients, actually. It's a really key point.
Okay, wow. So a clean scan doesn't rule it out then?
Absolutely not. That's a critical takeaway for you. Clinicians really need the full clinical picture.
Got it. But when it's abnormal, what do we see?
When there are abnormalities, they tend to be pretty subtle, often nonspecific. We might see these bright spots on certain MRI sequences called T2 or FLAIR hyperintensities.
Right, those bright spots indicating inflammation or swelling.
Exactly. They might appear in the white matter, especially frontal, temporal, parietal lobes, sometimes in the cortex, the outer layer, or deep gray matter structures, brainstem, cerebellum too.
You mentioned deep gray matter like the hippocampus. Is that common? I thought the paper said that was rare, actually, compared to, say, limbic encephalitis.
You're absolutely right to pick up on that. Good point. Hippocampal involvement, that T2 FLAIR brightness in the hippocampus, is indeed rare in NMDA.
Okay.
And that is a helpful point, differentiating it from other types of AE, like LGI1, that classically affect the medial temporal lobes.
I see. And does how bad the MRI looks match how sick the patient is?
Not consistently, no. MRI severity doesn't always correlate well with clinical severity, especially early on.
Huh. It's almost like the scan isn't telling the whole story initially.
Kind of, yeah. The paper mentions figure 1, showing a patient with NMDRA. What's that image tell us?
Yeah, what can we learn from that visual?
Figure 1, it basically shows just a couple of small, non-specific bright spots, these T2 FLAIR hyperintense lesions in the left frontal lobe.
Right, so not dramatic, widespread changes.
Not at all. It really drives home how subtle or even absent the findings can be in many cases.
Okay. What about using contrast dye? Does that typically highlight anything?
Contrast enhancement is only seen occasionally. When it does happen, it's usually the leptomeninges, those membranes covering the brain, that light up.
Interesting. Okay, so that's the acute picture. What happens down the line on follow-up MRIs?
Longitudinal studies tracking patients over time has shown some important things. Sometimes there's a reversible cerebral volume loss. The brain looks a bit smaller temporarily but bounces back.
Okay.
But irreversible cerebellar atrophy, permanent shrinking of the cerebellum that has been linked to poorer outcomes. And similarly, cortical volume reduction, a shrinking of the outer layer, has also been associated with worse outcomes. There's data from the Generate network suggesting long-term brain atrophy generally predicts a tougher road.
So MRI might hold some clues about prognosis then, about recovery.
It seems like it, but the findings have been a bit inconsistent across different studies.
Right.
The largest study did link an abnormal MRI at the start to worse functional status a year later. It's even part of a scoring system, the NEO score, trying to predict outcomes.
Okay, the NEO score.
Yeah, it includes initial MRI findings, and some pediatric studies also suggested an abnormal initial MRI meant poorer outcomes. But more recent data sort of nuances that.
How so?
Suggesting maybe the location of the lesions, like frontal or occipital lobes, might be more important prognostically than just whether the MRI is abnormal or not.
I see. So the pattern matters.
Exactly.
Yeah.
But despite the inconsistencies, the trend suggests, significant MRI changes early on might signal a more challenging recovery. That could be important information.
You mentioned pediatric studies. Are there specific things to know about kids with NMDR in their MRIs?
Yeah, a few things. Clinically, kids more often have movement disorders, cerebellar ataxia coordination problems, or hemiparesis, weakness on one side.
Okay.
They tend to have fewer of the neuropsychiatric symptoms compared to adults. MRI abnormality frequency about the same, 30 to 50%.
Right.
But volumetric studies measuring brain region sizes have shown kids can have pretty substantial brain volume loss, both globally and regionally, and it can impair normal brain development.
That's concerning. The paper also mentions overlap syndromes. What does that mean with NMDR?
Overlap syndromes are when a patient has NMDA receptor encephalitis and features of another autoimmune condition simultaneously.
Like what?
The main ones highlighted are overlaps with multiple sclerosis, MS, neuromyelitis optica spectrum disorder, NMOSD, and MOG antibody-associated disease. That's happy.
Okay. And how does that show up on the MRI?
Well, for NMDR-MS overlap, you can see the typical MS lesions on MRI T2 bright spots in characteristic spots like around the ventricles, near the cortex, in the brainstem, cerebellum, spinal cord, fulfilling MS criteria.
Right, the classic MS locations.
Exactly. And interestingly, these patients might accumulate more lesions over time than someone with just NMDR or even standard relapsing MS. Possibly because long-term treatment wasn't quite right. For NMDR, NMOSD, or MOGAD overlaps, the MRI might show things like optic neuritis close to the optic chiasm, or longitudinally extensive transverse myelitis, LTM.
LTM, that's the long lesion in the spinal cord.
That's the one. Long section of inflammation. You might also see brainstem changes or other white matter spots. These overlaps can sometimes mean more lasting deficits for the patient.
So recognizing these patterns on MRI is pretty crucial for treatment decisions, it sounds like.
Absolutely. You need to treat both aspects potentially.
Okay. The paper also mentioned advanced imaging. What extra information does that give us? Things routine MRI might miss.
Yeah, advanced techniques can pick up more subtle stuff. Structural changes like slight hippocampal volume loss or issues with white matter integrity, basically the health of the brain's wiring.
Okay.
And functional changes like disrupted brain networks. They mentioned things like the T1-T2 ratio, which is a measure related to myelin content being reduced in white matter tracts.
I see.
And these subtle changes can sometimes stick around long-term, even after immunotherapy, raising concerns about maybe accelerated brain aging down the road.
Fascinating. Okay, let's shift gears. LGI1 encephalitis, what are the key clinical features here?
LGI1 often kicks off with something quite specific. Faciobrachial dystonic seizures.
FBDS.
FBDS. Yeah, these brief, often very frequent jerking movements, usually affecting one side of the face and the arm.
Okay, very distinct.
Very. And then many patients go on to develop limbic encephalitis, memory problems, confusion, behavioral changes, temporal lobe seizures.
Right, the limbic system involved again?
Exactly. And importantly, catching and treating those FBDS early with immunotherapy might actually prevent the full limbic encephalitis from developing.
Oh, that's crucial.
Definitely. Also, low sodium levels, hyponatremia, are pretty common, around 60% of patients. And sleep disturbances are increasingly recognized too.
And long-term for LGI1?
Long-term, memory impairment is often the most prominent issue. But problems with attention, executive function, fatigue, depression can also persist.
Okay. So what does the MRI look like in LGI1? Similar to NMDR, can it be normal?
Yeah, during that FBDS stage, the MRI is often normal,
Okay.
though maybe up to a third might show some subtle T1 or T2 signal changes in the basal ganglia on the opposite side of the seizures.
Right.
But once it progresses to the limbic encephalitis stage, about 60–70% of patients will show those T2-FLAR hyperintensities, the bright spots, in the medial temporal lobes.
Medial temporal lobe, so hippocampus, amygdala area.
Exactly. Figure 2 in the paper shows a nice example of left medial temporal hyperintensity.
Is it usually just one side, like in the figure?
It can be unilateral or bilateral. But it's important to remember, even with limbic encephalitis, a significant chunk, maybe 30–40%, can still have a normal MRI.
Still. Okay.
So sometimes repeated scans, maybe higher resolution, are needed. And interestingly, during relapses, MRI abnormalities might actually be less common than in the first episode.
Huh. How do these LGI1 changes compare to other things that affect the temporal lobes, like viral encephalitis?
Good question. The paper notes that in LGI1 and also CASPR2 encephalitis, these medial temporal lobe hyperintensities tend to stay more within the temporal lobe.
Okay.
Less likely to spread beyond it, less swelling, less diffusion restriction, that sign of active cell injury, and less contrast enhancement compared to something like herpes encephalitis or CJD. So that can be a helpful clue.
Got it. Anything else seen on MRI and LGI1?
Yeah, up to 30% might also show T2-FLAR hyperintensities along the corticospinal tract, that main motor pathway.
Okay. What about long-term MRI findings in LGI1? Does the initial picture predict the future?
Well, here's something really important. At long-term follow-up, almost all patients with LGI1 encephalitis develop some degree of hippocampal atrophy shrinking.
Even if their initial MRI was normal?
Even if their initial MRI didn't show those acute changes in the medial temporal lobes.
Wow.
And the amount of atrophy often correlates with how bad their memory impairment is.
That makes sense.
And there's also a link suggesting that having those initial bright spots, the hyperintensities in the temporal lobes during the acute phase, is associated with greater functional disability later on.
Okay. So initial changes might matter for long-term function. What about advanced MRI and LGI1? Does it show more?
Yeah, similar to NMDRR, advanced MRI showing that LGI1 isn't just a limbic system disease.
Right.
Resting state fMRI, looking at brain networks, finds altered connectivity in sensory and visual networks even where there's no obvious structural damage.
Interesting.
Damage to the hippocampus seems to disrupt its connection with major brain networks, and changes in the default mode network, that resting network, correlate with memory performance.
Like the brain is trying to compensate.
Possibly, yeah. And there's evidence the white matter tracts connecting limbic and other brain areas might be affected too, which could explain why some patients have both limbic and other symptoms.
Very cool. Okay, let's pivot to CASPR2 encephalitis. How is this one different clinically from LGR1?
CSPR2 can show up in a few ways. Limbic encephalitis is one, similar to LGI1, but also Morvan syndrome.
Morvan syndrome.
Yeah, that involves peripheral nerve hyperexcitability, think muscle twitching, stiffness plus cognitive issues, seizures, and dysautonomia, problems with the autonomic nervous system.
Okay, quite different.
And also acquired neuromyotonia, which is more focused on the muscle cramps, stiffness, delayed relaxation. But again, limbic encephalitis with memory loss, confusion, seizures is also common, and symptoms can overlap.
Right. Figure 3 shows a CSPR2 case, again with medial temporal changes. Looks quite like the LGI1 image.
It does. And the MRI findings reflect that clinical overlap.
So if someone just has the neuromyotonia or Morvan syndrome, is the MRI normal?
Usually, yes. If it's just the peripheral nerve or autonomic symptoms, the brain MRI is typically normal.
Okay.
But in CASPR2 patients who have limbic encephalitis, then yes, we often see those T2-FLAR signal increases in the medial temporal lobes, much like in LGI1. Figure 3 shows that nicely left medial temporal hyperintensity and some swelling.
And do these changes stick around?
They can evolve into hippocampal atrophy later on, similar to LGI1. And if a patient happens to have cerebellar ataxia with CASPR2, you might see cerebellar atrophy on follow-up scans.
Okay. Do the initial bright spots usually fade?
In most cases, yes. Those acute signal changes tend to normalize over time.
And contrast enhancement in CASPR2. Common. Rare.
Very rare. Really just single case reports mentioning some enhancement in the basal ganglia or medial temporal lobes. Not a typical feature at all.
Got it. Okay, next up, GAD encephalitis, associated with GAD antibodies. Clinical picture.
GAD encephalitis often presents as limbic encephalitis, stiff person syndrome, or cerebellar ataxia, sometimes overlapping.
Stiff person syndrome.
Yeah.
Right. And limbic encephalitis again.
Yep. Memory loss, confusion, seizures. Figure 4 shows a case with bilateral T2-FLR hyperintensities in the medial temporal lobes.
Bilateral, okay. So affecting both sides seems common here.
It does seem quite common, especially in the limbic encephalitis presentation. Marked T2-FLR hyperintensities, often with noticeable swelling, in both medial temporal lobes, hippocampus, and amygdala, as you see in Figure 4.
Right.
Some studies using automated volumetry have even found the hippocampus and amygdala are actually larger than normal in the acute stage, probably due to that swelling.
Interesting. What about follow-up? Does the swelling go down? Any lasting changes?
The swelling usually resolves, yes. But even if those bright spots improve, often significant sclerosis, which is like scarring and volume loss, remain, especially in those medial temporal lobes.
So lasting damage is common.
It seems so. And if cerebellar ataxia is the main feature, you might see cerebellar atrophy develop, typically without brainstem involvement. The paper notes no specific MRI patterns have been reported just for the stiff person syndrome presentation.
Okay. And contrast, does GAD encephalitis enhance?
Some cases show faint contrast enhancement of those medial temporal lobe lesions. Not always, but it can happen.
All right. Moving on to GABA B receptor encephalitis, clinical features.
GABA B is primarily a limbic encephalitis. Frequent seizures are a big feature, along with memory loss and behavioral changes.
Okay, LE again. Any other features?
Less commonly, you might see cerebellar ataxia or brainstem involvement, causing autonomic problems or issues with cranial nerves. Figure 5 shows bilateral medial temporal lesions again.
Seems like that medial temporal lobe area is really a hotspot for autoimmune attack, doesn't it?
It really does. And yes, the MRI in GABA is usually consistent with limbic encephalitis. Most patients show T2-FLR hyperintensities there, like in Figure 5.
Anything unique about the pattern?
Well, some individual cases have shown a pattern that looks a bit like laminar necrosis, specifically in the CA1, CA2 regions of the hippocampus.
Okay, that's specific.
Yeah. Other findings can include general white matter changes, sometimes suggesting reduced blood flow, like diffuse ischemic lesions. And if there's cerebellar involvement clinically, you might see matching bright spots in the cerebellum on MRI, maybe extending into the brainstem or basal ganglia.
How do these findings evolve? Do they resolve?
Generally, yes. The imaging changes tend to resolve as the patient gets better clinically.
But any residual changes?
Some cases can be left with cortical atrophy, especially in the temporal lobe.
And contrast enhancement in GABA B?
Not typical.
Yeah.
A few cases showed weak temporal enhancement. One reported meningeal enhancement, and one interesting case had that long spinal cord lesion, LDTM, in the thoracic spine.
Okay. Next is GABA receptor encephalitis. How does this one look clinically?
GABA often presents with pretty significant cognitive problems, disorientation, memory impairment. A key feature is often refractory seizures, meaning hard-to-treat seizures, sometimes even status epilepticus, which is prolonged seizure activity.
Wow, sounds severe.
It can be. Depression, psychosis, mutism can also occur.
And the MRI in GABA? Usually abnormal.
Yes, MRI is frequently abnormal here. The typical pattern is quite different from the others we've discussed.
How so?
It's often multifocal, confluent, T2-FLR hyperintensities, widespread bright areas merging together, but involving both cortical and subcortical regions pretty extensively.
Which regions specifically?
Medial temporal lobes can be involved, but also orbitofrontal cortex, parietal and occipital lobes towards the back, the insula deep inside, basal ganglia, cerebellum. It's often described as cortico-subcortical lesions, quite widespread.
Okay, so a more diffuse pattern.
Generally, yes. And sometimes you can see diffusion restriction in those areas too.
What happens to these lesions over time?
In many cases, they do resolve. But sometimes generalized atrophy can develop later on.
And contrast enhancement.
Rare. Just single reports of enhancement in the parietal lobe or some focal leptomeningeal enhancement.
Got it. Okay, IDG-LON5 disease. You said earlier this one has a really diverse clinical picture.
It really does. Sleep disorders are very common, often REM sleep behavior disorder. Also, Bulbar syndrome, problems with speech, swallowing. Movement disorders, neuromuscular issues, cognitive decline, eye movement abnormalities. It's a real mix.
And there's a genetic link, too.
Strong association with specific HLA types, yes. HLA DQB 105.
Okay. What about the MRI? The paper said it's often unremarkable.
That's been the finding in larger group studies, yes. MRI frequently looks normal despite significant symptoms.
Another case where MRI might not show much.
But there are increasing case reports describing various abnormalities. It's a growing list.
Like what kind of things?
Things like leptomeningeal inflammation, atypical inflammatory lesions with brainstem or hippocampal atrophy later on, T2 bright spots in the hypothalamus, hippocampal swelling,
Okay.
also symmetric T2 hyperintensities in the cerebellum, its connections, peduncles, and the brainstem that sometimes improve with treatment. And interestingly, some cases show bilateral swelling and brightness of the trigeminal
The
nerves.
trigeminal nerves.
Yeah, the ones for facial sensation and chewing. Seeing that in a patient with suggestive symptoms like bulbar problems might be a diagnostic clue. Reduced diffusion in some areas has also been reported.
The paper mentioned PET scans, too.
Right. P scans using tracers for tau protein have shown tau deposition in the brainstem and cerebellum.
And that matches the pathology.
Exactly. Postmortem studies show Iglon5 is a tauopathy, so the PET findings fit with that.
What about follow-up MRI in Iglon5? Changes appear over time.
Atrophy has been seen in some patients on follow-up scans, often in the brainstem, midbrain, cerebellum, hippocampus. A recent study even pinpointed specific substructures within the brainstem, nucleus accumbens, and basal ganglia that seem prone to atrophy.
So subtle changes might be trackable. Contrast enhancement.
Very rare, just one case report of temporal lobe enhancement that later resolved.
Okay, last one on our list. GFAP astrocytopathy. Clinical features.
GFF often presents with a mix of encephalopathy, general brain dysfunction myelitis, which is spinal cord inflammation, optic neuritis, ataxia, and sometimes psychiatric issues. Fever, headache, visual problems are common initial symptoms.
Okay. And the MRI, are there characteristic findings here?
Yes, GFA often has a quite distinct MRI pattern. You typically see extensive confluent, meaning merging together hazy T2 hyperintensities, often predominantly around the ventricles, the periventricular regions.
Hazy. Okay.
Yeah, not always sharply defined. The brainstem, diencephalon, cerebellum, corpus callosum, optic nerves can also be involved. But the real hallmark
What's that?
is a characteristic pattern of contrast enhancement, linear radial enhancement along the blood vessels, especially in that periventricular white matter, seen in about half the patients.
Ah, a specific enhancement pattern. That sounds useful.
Very useful when present. Leptomeningeal enhancement is also common. And in the spinal cord, about half the patients have LDKM, that longitudinally extensive transverse myelitis, usually in the thoracic spine.
Is this pattern always seen, or is there variability?
There can be variability. The paper mentions a recent report of a patient with severe hippocampal and degenerative brain atrophy, plus LETM, but without those typical hazy cerebral T2 lesions.
So it can look different sometimes.
It can, yeah, highlighting heterogeneity even within a single AE type.
But that radial contrast enhancement pattern is the key thing to look for.
It's a major clue, seen in about 50%. And enhancement can also extend into the brainstem, spinal cord, or affect the leptomeninges in nearly half of cases.
Okay, wow. We've covered a lot of ground. So bringing it all together, what are the main conclusions from this review on MRI in autoimmune encephalitis?
Well, I think it really underscores the complexity, the heterogeneity of these conditions, but also there are shared patterns, especially that limbic encephalitis picture we saw recurring.
Right.
MRI is clearly absolutely vital, both for diagnosis and potentially for prognosis.
Even though it can be normal sometimes.
Exactly. And while some AEs have pretty nonspecific lesions, others, like GFAP with that radial enhancement, have more characteristic patterns that really help clinch the diagnosis or rule out other possibilities.
And there's work being done on using MRI to predict outcomes more accurately.
Yeah, initial research is looking beyond just normal versus abnormal. Can lesion location or size or number tell us more about how a patient might do? But we definitely need more longitudinal studies.
To track how things change over time.
Precisely. To understand the evolution of MRI findings and maybe identify better imaging markers for each specific AE type. Follow-up imaging is also key for spotting relapses or long-term issues like atrophy.
And connecting the imaging patterns to the symptoms seems crucial.
Absolutely. Linking the structural and functional imaging findings to both acute symptoms and long-term outcomes is really pushing our understanding forward.
It's really amazing, isn't it, how these different antibodies attacking specific brain targets can lead to such varied pictures on an MRI scan?
It truly is. And the ongoing research using advanced MRI techniques, things like DTI to look at white matter tracks or quantitative mapping for tissue properties, holds huge promise.
Promise for what?
For potentially detecting even more subtle changes, maybe predicting severity or outcomes better, and really complementing the immunological testing side of things.
So thinking about all this variability, the normal scans, the overlap syndromes, what do you see as the biggest challenges left in diagnosing AE?
That's a great question to ponder. I mean, the overlap in symptoms and imaging between different AEs and even with non-autoimmune conditions is a major hurdle.
Right.
And the fact that the MRI can be normal, especially early on when treatment might be most effective, is a huge challenge.
Definitely. So how might future advances help imaging antibody tests?
Well, hopefully we'll see continued improvements in antibody testing, making them more sensitive, more specific. And on the imaging side, maybe more refined quantitative MRI techniques, perhaps even using AI to spot subtle patterns the human eye might miss.
AI in radiology.
Could be powerful here. Combining that with better antibody tests could really improve diagnostic accuracy, leading to earlier, more targeted treatments. Understanding those long-term MRI changes and how they relate to how patients actually do will be key for personalizing care. It really is this dynamic dance, like you said, between the immune system and the brain.
A fascinating and complex dance indeed. Thank you so much for walking us through all of this. It's been incredibly insightful.
My pleasure. It's a rapidly evolving field.
And thank you, our listener, for joining us in this deep dive.